you all here today. My name is Shannon Welby, and I'm from Untitled Chapter. And today I have the absolute pleasure of introducing Megan Berg. Megan Berg is a SLP and the founder of Therapy Insights, which is a company that creates resources for rehabilitation clinicians rooted in EDP, person-centered care, health literacy, and lifelong learning. She's based out of Western Montana, and today she will be speaking on 8 questions to transform your clinical practice.
Thank you. Good morning, everybody. And I just want to say thank you for being here. Thank you for coming to this talk. Thank you for showing up for MSHA. Thank you for showing up for yourselves. I feel like it's been a really intense and challenging last couple of years, to say the least. So I hope this time is a time of reconnection and rejuvenation and getting new energy for you. And for the next hour and a half, we're going to be talking about these 8 questions that I have promised you will transform your clinical practice, which is a tall order, so we'll see if I deliver. How many here work with adults or want to work with adults? And kids, or both? Okay. Excellent. So, and did I miss anybody with the guided notes? Everybody got a copy? Great. And I'll give you a heads up that I am 16 weeks pregnant, and it's going super great, but I am having some low blood pressure issues, so I've brought a stool, so if I sit down, that's why. I promise I'm not being lazy. All right. So first I want to start with some disclosures. So I am the owner of Therapy Insights, and you'll see some of our graphics throughout the presentation. And as you will come to learn, I have a distinct bias towards the social or empowerment model of healthcare. And I'll tell you a little bit about myself. I was going through these slides, and I have this slide in there because I've been giving so many presentations over Zoom, and usually my dogs are right behind me with all of their squeaky toys, or that's like the perfect time that they decide to wrestle every time I open Zoom. So I thought I would leave it up there anyway, even though we're actually getting to be in person now. I grew up in Nebraska, and I went to high school in a zoo, which has absolutely nothing to do with what we're talking about today, other than it was one of those life experiences that taught me that just because things have been done a certain way for a really long time doesn't necessarily mean that that's how things always have to be done in the future. And so we had 2 broken down portables in the back of the children's zoo in Lincoln, Nebraska, and it's still there. They have a new shiny building now, but it's part of the public school system. So we had all the regular high school curriculum. We had 4 teachers and about 100 students, and everything was just done very differently. So right out of high school, I feel like I had this perspective of kind of looking at things differently and thinking about how we can innovate and try new things. And then I majored in history, randomly enough, at the University of Otago, which is on the southeast side of the South Island of New Zealand. And I had no idea that speech pathology was a thing until many, many years later. And so for a while, I got pretty deep into a career in science communication. And so my job was basically to embed myself with different groups of scientists and work with them around the world to try to take what their research was and distill it into a story that people could relate to and understand. And it was an incredible experience. I got to meet a lot of different people, curriculum developers, teachers, journalists, writers, designers. And again, this would kind of come into play in my career as a speech pathologist. I did go to grad school at CU in Boulder, and then I interned at the Pine Ridge Indian Reservation in South Dakota and Madonna Rehab Hospital in Nebraska, both of which were phenomenal experiences. And I survived 1 year as a school SLP, which taught me how to have great respect for everybody who makes a career out of that. I worked outside of Fort Collins, and then I ended up moving here where I worked in skilled nursing, long-term care, and post-acute care. And when I started working with adults, one thing that I found that I was passionate about was health literacy and making sure that the people that I was working with really understood what was going on with their own bodies so that they could make their own decisions about what they felt was best for their health. And has anyone pulled anything like this out of a therapy closet? Like maybe a little bit outdated. This is one thing I found when I was working here in Missoula, and I pulled it out of the closet, and there were like things taped together and obviously very outdated, not very updated information. And so I realized that I needed to create resources for the patients I was working with. And so I took my background in science communication and graphic design, and I just started creating handouts and materials for patients. And I was sharing these online and getting requests from around the world to have them translated into different languages. And that's when I realized, like, I am not the only therapist searching for materials, especially for adults. And I'm not the only one who values health literacy and making sure that patients understand their own bodies and can make their own decisions. So that's how Therapy Insights started, and we've expanded, and we now serve speech, occupational, and physical therapists around the world. But we're not here to talk about Therapy Insights, but that's just a little bit about me. What we are here to talk about is this list of items. So we're going to start off talking about the traditional medical model, kind of the historical context, where that came from, because it's very much the water that we're all swimming in right now when we work in healthcare in the United States today. And then we're going to contrast that with the social or empowerment model of healthcare, and just know that it's called different things. It's a theory that's been around for a few decades, but it's given a lot of different names. I think the social model of healthcare is the most popular because it was adapted from the disability model. But if you do any research later on this, you'll see that it has lots of different names. And then we'll get to those 8 questions that I've promised will transform your clinical practice. And then we've got 3 case studies to look at, 1 or 2 that are adult-based and 1 that's pediatric-based. And then at the very end, we're going to talk about how the empowerment model ties into diversity and looking towards the future of speech pathology and improving diversity to improve innovation within our field. So that's our plan. Okay, so first, I just kind of want to define what is the traditional medical model. So what is the model that's kind of pervasive today that anyone in healthcare who walks into a facility is kind of expected to abide by? And it's generally this idea that people are passive receivers. There's lots of different providers that are coming at the person, and they're not necessarily seeing them as a person, but seeing them as their diagnosis. And recently, there's a big shift towards patient-first language. And so historically, we've seen people be called like the brain-injured patient and things like that. So I think that speaks to kind of the culture of seeing the person just as their diagnosis, not as a human being. And with the empowerment model, we're trying to pull the person out of that circle and see that they have their own personal values, they have their own knowledge and understanding of their condition, and that'll change over time. They have their own personal priorities that also change over time. They have a right to personal choice, whether it aligns with what we would choose for them or not. They have their own personal history and trauma that plays into their choice and their preferences. They have an identity completely outside of the diagnosis that's often not seen by providers. And they have their own spiritual path, which again plays into how they make decisions, or how we all make decisions. But this shift towards this empowerment model has been generally quite slow. And there's been a lot of research, like when I was looking into the papers that have been published for this talk and kind of looking at when was this last really popularized, and it was in the 1970s. And we're still kind of like, still pushing towards it, still talking about it, but we're not quite there yet. And I told you that I majored in history, so I'm always looking at things through a historical lens. So like, what happened to get us to where we are today? And I'm going to talk about 3 cases in history that I think really represent how we got to this traditional medical model. And the first you're probably familiar with is the case of Henrietta Lacks. So Henrietta was, she was 31 years old in 1951, and she went to Johns Hopkins University complaining of pelvic pain, and she had some vaginal bleeding, and they took a biopsy and found that she had cancer. And at the time, there was a researcher at this particular hospital that was collecting these biopsy cells to see if they would survive in a lab so that they could do medical research. And what was completely unique and unprecedented about Henrietta's cells is that they not only stayed alive, which a lot of the other cells did not, but they reproduced at this incredible rate. So that made them perfect for all kinds of medical research. And so they took her cells, and her cell line has been used ever since the 1950s, and it's been attributed to breakthroughs in the effects of zero gravity, the development of the polio vaccine, study of leukemia, the AIDS virus, and cancer worldwide. But the problem was that Henrietta was never informed that this was happening. They never asked for her permission. They never got her consent. They never provided any financial support, even though they were being paid to sell her human cells, and her family also never got any compensation. Although I was looking to see if there had been any updates, and the Howard Hughes Medical Institute did do a 6-figure donation to her family last year. But to date, you can still go online, and any of us can just add her cells to our cart and check out and do our own medical research based on her body without her consent or any financial support for her family. Another story that's come up recently, especially with the COVID vaccine, is the legacy of the Tuskegee syphilis study. So this was a study that was done by the U.S. Public Health Service and the CDC, although the CDC is now like, okay, well, we were like kind of involved, but not really, because they don't want to have their name attached to it. But it was a study that was done between 1932 and 1972, and basically they were trying to figure out what would happen if syphilis went untreated. And so they recruited 399 black sharecroppers in Alabama, and they promised them like the best health care that they would ever get. They promised to take care of their families. But what ended up happening is that in 1947, penicillin came out, and that became the treatment for syphilis. So the problem of syphilis was resolved, but the participants of this study were never informed about this cure, and they were not given the option to remove themselves from the study, even though at that point the study was moot because they had a cure for syphilis. So by the time the study was exposed and shut down in 1972, 128 of the men involved had died from syphilis, and 40 of their wives and 19 children had become infected. And so I think this just speaks to this idea that we have this hierarchy where we have healthcare providers that are making decisions about patients' bodies and kind of the trajectory of their treatment without their knowledge or consent. And it's been interesting to listen to everyone talk about this study during the time of COVID. I liked the woman on the right that NPR interviewed. I really liked what she had to say, because she was basically saying, like, yes, this is a problem. Yes, this happened. Yes, this is probably why a lot of black people do not want to get the vaccine. But also, the other reason that black people do not want to get the vaccine is because of the way that they are treated in our current model of healthcare. So a lot of decisions are made for them. There's this kind of idea that they don't know what's best for them, so we're going to decide that for them. The last piece of history that I wanted to talk about is, of course, eugenics, which was a huge movement in the United States. And I think historically we look at it through the lens of Nazi Germany and everything that happened during the Holocaust. But it was actually the United States that inspired Hitler with our sterilization programs. So again, a lot of it is based on scientists and healthcare providers coming together, making decisions for everyone else about who should be sterilized and who should not be sterilized. I think one of the most striking stories to me is the story of Carrie Buck, who's pictured here on the left. And when she was 17 years old, she was raped by a family member, and she became pregnant, and she was admitted to the Virginia colony for epileptics and feeble-minded on the grounds of feeble-mindedness, incorrigible behavior, and promiscuity, even though she had average grades and was even on the honor roll at one point, and her teachers never had anything to say about her behavior. So the facility wanted to sterilize Carrie, and she did not want to be sterilized. That was her choice. And somehow the case, she had a lawyer, and the court case went all the way to the U.S. Supreme Court, which found that the Virginia Sterilization Act of 1924 did not violate the U.S. Constitution. So that kind of opened the door for over 24 states to enact similar sterilization laws, doubling American sterilizations from 6,000 to more than 12,000 by 1947. And a lot of these laws are still on the books when you look at people who are incarcerated. The fight is still going on to end these sterilization laws in the United States. So again, there's just kind of this trend throughout American history of making decisions for people without their full knowledge or consent. And even when they kind of fight back and say, no, I have my own right to make my own choice, we have the US Supreme Court squashing that. So, this is where I think the word compliance comes in. And compliance, or like a patient being compliant, is a word that I used in my documentation because I think I read it, like I read somebody else's documentation, and I was like, oh, like that's how we say that a patient doesn't want to do what we're saying that they should do. And that like takes the pressure off of us, and it takes the responsibility off of us, and I can just say, oh, this patient is non-compliant with XYZ. And so healthcare compliance has become a very popular term to kind of document the consistency and accuracy with which someone follows the regimen prescribed by a healthcare provider. And like I said, a lot of the literature about this more empowering medical model was really popularized in the 1970s, and I like this quote by George Engel. He said, "The dominant model of disease today is biomedical, with molecular biology its basic scientific discipline." So again, the focus is the diagnosis. It assumes disease to be fully accounted for by deviations from the norm of measurable biological variables. So again, like a lot of our standardized tests are looking at how far are they deviating from the norm within this label and this diagnosis. It leaves no room within its framework for the social, psychological, and behavioral dimensions of illness. The biomedical model not only requires that disease be dealt with an entity independent of social behavior, it also demands that behavioral aberrations be explained on the basis of disordered somatic processes. So again, compliance is an ideology that reinforces that hierarchy. And so what I've started doing is I've completely gotten rid of the word compliant or compliancy, and I've replaced it with choice. So instead of saying this person is non-compliant with plan of therapy, I say this patient has made the choice to discontinue therapy at this time per their request. So, if we were to break it down, the central focus of the traditional medical model is the diagnosis. So not a lot of room for all those other human variables around it. The treatment goals all center around the idea of eliminating or reducing the severity of the diagnostic condition. So I think when you look at a lot of our standardized tests in speech pathology, they very, very much fit within the traditional medical model because we're only looking at that diagnostic condition and we're not necessarily looking at patient-reported outcome measures or quality of life. And then we measure success by have the signs and the symptoms of the diagnosis decreased. So if we compare that to the empowerment model, instead of the diagnosis being the central focus, the person is the central focus. The treatment goals all center around the person's well-being, their life goals, their meaningful activity, roles, and purpose, which could be related to the severity of the diagnostic condition, but not always necessarily. It's a little less black and white and a little more in the gray area of what it means to be human. And then rather than measuring success by measuring how the signs and symptoms of the diagnosis have decreased, we're measuring, is the person able to live a life that is meaningful to them? And then the question I always get here is the dilemma of insurance companies and the fact that measuring a person's quality of life is very difficult, and it's not something that insurance companies are always excited about. And my response to that is always that it's a matter of educating the insurance companies as much as possible, and then really working to find high quality of life measures, and then using patient-reported outcome measures in your therapy plans. So before starting therapy, having some kind of standardized system, even if it's something that you're making up, it's a rating system that they can self-rate how they're able to do the things that they really want to do, and then maybe returning to that at the end of your therapy journey and seeing if there's any change. So those are quantifiable numbers that you can report to insurance companies. And again, not to say that the standardized tests are useless, but I think we need to be combining those with quality of life and patient-reported outcome measures. Okay. So we're going to dive into these 8 questions, but first I want to just have you imagine like you're walking into a patient's room for the first time and you're introducing yourself, and just think about like, what do you usually say? What words do you use to describe yourself? How do you kind of start off that conversation? And I don't know if you're like me, but a lot of times I feel like this.
Hi, my name's Molly. I'm here to see you for speech therapy today. Speech therapy? I can talk just fine. Yeah, I know you can talk just fine. With speech therapy, though, your goals are actually to improve your swallowing. Swallowing? What's wrong with my swallowing? I've been swallowing my whole damn life, lady. I'm 85 years old. I can swallow just fine. Just fine. Yeah, I know you may think you're swallowing fine, but actually you've gotten aspiration pneumonia recently because your food and your liquid was trickling down the wrong way. Listen, lady, I can swallow just fine. I just sometimes cough and get a little choked up when I eat and drink just about anything. But we also have some goals for cognition for you.
I don't know if I can get the video.
Hi, my name's Molly. I'm here
It's worth a shot.
I came here because I kept falling and hitting my head, making my legs weaker. I'm here to work my legs. Okay. You have a good time with that.
Okay, I can send the link out with the video. It's very funny because she's got glasses and she's got like a Snapchat filter going on. Okay, so then my question is, what if we did a complete 180? So when I walked into patients' rooms, what I used to do is say, hi, my name is Megan. I'm with speech therapy. I hear that you've been having challenges with XYZ. That's what I specialize in. I'm here to help you. And I found that I got a lot of reactions like what she was talking about in the video, where it's like, well, I don't need help. What is a speech therapist? Which that's a confusing name on its own. And I keep saying that we need to change our name to neurolaryngologist, but that hasn't caught on yet. But it's like this confusing dynamic with people where they're just wondering what I'm doing there. They're wondering why I know all this information. Maybe they're feeling like their privacy is a little bit violated. And so what these 8 questions do is kind of completely pivot that first introduction with a patient. And not all of the questions are sequential. It's not like you have to walk in the room with your list of 8 questions and ask them all at once. You might only ask the first one that first day that you meet with them, and then you can slowly ask the other ones over time. Maybe there are some that you just never ask. Maybe there are some that you ask at the very end. But all of these questions are based on Atul Gawande's book, Being Mortal. Has anybody read this book? So good, right? If you have not read it, I recommend booking it to Barnes & Noble after this conference and getting a copy. I think he's now working for Biden, is that right, in his administration? But he is a surgeon, and he's done a lot of work, not only with kind of doing a better job with surgery. He wrote another book called Checklists, I think, and just kind of how to do really detailed surgery work. But he's also done a lot of work in end-of-life care, and his whole book, Being Mortal, is about that journey. And he makes the case for the empowerment model pretty powerfully. So he says, we've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being. And so all of these questions that I've written are very much based on his work and his writing. Okay, so question number 1 is, what is your understanding of where you are with your health? And this completely flips it. Like I said, I used to walk into rooms and say, I know this about you, and this is why I'm here. But when we flip it, I've always been like, really, actually, and like I feel embarrassed about this, but I'm always surprised how much people know about their health. Like even people who are coming out of encephalopathy or like any kind of brain injury, they know more than I think they do, and I don't give them enough credit. And so by asking this question, they're able to kind of process what's happening with them, and they're able to tell me rather than me telling them. Question number 2 is, are there any gaps in knowledge that I can address as a clinician? And this is a question that you can verbally, explicitly ask, or you can infer it. Just kind of depends on the person, and it depends on your rapport. This is a chance to kind of gauge like how much can we work on health literacy. So trying to gauge like, are they able to Google things? Do they have a phone? Are they looking up these things on their own? If I gave them a handout, would they be able to understand it? Do I need to walk through that handout with them? Do I need to provide copies of the different handouts that I'm giving them to maybe their family or their friends so that they can look at that together and talk about it together? But I think it's absolutely vital that whatever gaps there are, we need to be addressing, and not only verbally, but providing that tangible written information, which obviously I'm passionate about because that's what I do. And there's all kinds of different statistics and research out there, but about 10 to 15% of medical information is remembered correctly with spoken instructions versus over 80% accurate recall with visuals and text. And I know this, like when I go to see any kind of provider, I bring a notebook and a pen with me and I write things down. But a lot of patients aren't in that position to have that kind of self-advocacy. And so we just need to be aware of like, what are their gaps? And not only what are their gaps, but like what is their health literacy like, and how can we help bridge those gaps with information that's going to stick? And we're not there to give them information that's going to help them make the decision that we want them to make, but make the decision that's most aligned with their own values. Okay, question number 3 is, what are your worries for the future? And this is such a powerful question because we are acknowledging that they have worries, so we're there to listen. And again, for me, it's been a switch from explaining like all the things that could go wrong if we don't do speech therapy versus having them explain to me what they already know are the risks of their situation. And then I also find that the answer to this question is, it just pretty much writes all of my goals for me. So if they're worried that they're not going to be able to go to their granddaughter's soccer game, like boom, that's a goal. If they're worried they're not going to be able to order their favorite coffee, that's a goal. If they're worried they're not going to be able to go home, that's a goal. And then from there we can move to question number 4, which is, what are your hopes and priorities? And again, we're just here to listen to them, and this can help us tailor those goals and get them to be a better fit to what they're actually looking for. Question number 5, also very, very powerful, especially in any kind of inpatient setting. What are you willing to sacrifice, and what are you not willing to sacrifice? And the reason this question is so powerful, I think, is because any one of us who enters into a healthcare system, whatever that looks like, we immediately are giving up a lot of independence, and especially in any kind of inpatient setting, we're just sacrificing a lot of our own choices about what we're eating, when we're sleeping, who's in our space with us, sharing a bathroom, like all of those things. So asking them to define, like, what are you willing to sacrifice, big or little, and what are you absolutely not willing to sacrifice, can help us guide therapy as well. Question number 6 is, what are the options? And this might be a question that you're, again, explicitly asking at the very beginning. Obviously, it depends on the case and what's going on. It might be a question that you address multiple times throughout a day, or multiple times throughout a week or a month. It might be a question that you only address at a family care conference or something like that. But basically, you're always trying to create an environment where there's not a predetermined endpoint that the healthcare providers are all working towards, but creating an environment where there are multiple options on the table at all times, depending on, different variables that may go different directions throughout their recovery. Question number 7, and this is the question that's missing in the traditional medical model, is, what is your choice? And for whatever reason, like, this is the hardest question I feel like our system has, not only in asking, but then also in honoring, which is the 8th question, which is, how can we best support this choice? And often what happens is either the person is not asked what their choice is, or they verbalize their choice, but then we're like, okay, well, that's ideal, but really we need to do it this other way because of these safe. I mean, obviously there's going to be times where family is involved and there are situations where the choice is out of their hands, but I think there are a lot of times where the choice is something that we can honor. We're just not totally honoring because of our current restraints on our system. Okay, so those are the 8 questions. And what I want to do now is apply them to those 3 case studies. So I'm going to read this case study out loud, and then we're going to go through those 8 questions, and we have kind of like mock answers based on the patients. So case study number 1, Brian is a 38-year-old male who survived a traumatic car accident resulting in damage to the right frontal lobe and a broken leg. He has spent the past 3 weeks in rehab therapy working on left neglect, insight, impulsivity, safety awareness, and mobility. He is emotionally ready to go home and return to work, but physically and cognitively there are concerns that this isn't a good option right now. He is married with 3 children and works as a programmer. Due to the nature of his injury, he does not exhibit the ability to have accurate insight into his limitations in prognosis. His short-term memory is impaired, and there is concern of safety limitations in a home environment when he is alone or sole caregiver of the kids. The therapy team believes he would benefit from an additional 9 weeks of therapy before going home. So question number 1 is, what is your understanding of where you are with your health? And he says, I understand that I have a brain injury. I've been working hard to recover from it, and I want to go home. I know I would be able to do more at home. Everyone tells me that they're worried about my safety, but I'll be fine. Sound familiar? Are there any gaps in knowledge that I can address as a clinician? And again, this is something we might explicitly ask or just infer. So he might be missing some information about the different hemispheres of the brain, maybe not fully understanding anosognosia and how hard it is for him to really have insight and awareness based on the nature of his injury. And then maybe providing some more information about left neglect and how that plays into the safety concerns. So we can provide different resources, cover those topics in therapy, talk about anosognosia. One of my favorite things to do is interdisciplinary. So this is a map of the brain with different impairments that can happen based on the location of damage. And so passing around a map like this to all 3 disciplines, SLP, OT, PT, and having everybody talk about what they're working on in therapy, because I think sometimes what happens is speech therapy carries the burden of explaining the cognitive deficits, and then the speech therapist kind of becomes the person that the patient is fighting, whereas if it's a group conversation and it's a group effort and it's the therapist and the patient against the brain injury rather than the patient against the speech therapist, that's a lot more, you can get a lot more done. Talking about the differences between the left and the right brain, just giving more insight into the fact that he has a right brain injury and what that entails. Talking about self-awareness and providing concrete steps to improve that awareness. The next question, what are your worries for the future? So his worries are not seeing his kids grow up, not being able to help his wife, being stuck in a facility, everybody's worst fear, never getting back to the way things were. So this might be a chance, at least for that last point. I like to talk to people. There's a great book called To Root and to Rise by Starr, and she's a survivor of a traumatic brain injury, and she really digs into the transformation in identity that happens before a brain injury and after a brain injury. And she's got all kinds of kind of worksheets and questions throughout her book for the brain injury survivor to think through what their life looked like, what it looks like now, what they're struggling with, and what it could look like in the future. Not that it's worse, but just that it's different. And then addressing concerns about being stuck in a facility and trying to normalize any kind of long-term rehab stay that doesn't necessarily mean long-term care. And then explicitly saying that you're writing goals that address him being involved with his kids and his wife. So that might look like co-treating with OT or PT in the kitchen and being like, okay, what's something that you would do with your kids at home? And maybe he wants to make breakfast. And then it's like, okay, we're gonna go through the whole making a breakfast routine with all of the knives and the stoves and everything. And the therapists are gonna pretend to be the kids, and we're just gonna see like kind of what happens and then provide feedback about how to be more safe in the kitchen. So we're making it super, super functional so that it's not like he's just in this facility working on worksheets when he really just wants to be home with his kids. What are your hopes and priorities? Obviously going home, continuing to work, and getting back to normal. What are you willing to sacrifice and what are you not willing to sacrifice? So he's willing to sacrifice a change in role at his job. He's willing to work from home with limited hours. He's willing to invest the time and energy for outpatient therapy. He's willing to sacrifice his privacy for home health to come into his house, and he's willing to sacrifice driving for now. So again, I think that's why it's such a powerful question, because we often walk away with this long list of things that people are sacrificing or willing to sacrifice, and then we can at least acknowledge it and like bear witness to that. But he's not willing to sacrifice living in a facility and not getting to see his kids. So then the next question is, what are the options? And again, this is where like just lay it all out on the table. Like what could possibly happen? What are all of the different paths that we could go down? So he could stay in the facility another 9 weeks and maybe make more progress. He could go home and do outpatient therapy and home health. He could do a shorter stay, so maybe a month would feel better than 9 weeks. Maybe it's possible for extended family to come help his wife, and then that would allow them to bring his kids to the facility for more frequent visits. So just getting really creative with all of the different options. And then, what is your choice? I want to go home now, says every person with a right brain injury ever. And so then it becomes, how can we best support this choice? And obviously there's some complexity with brain injury if the family is not able to safely care for this person and they're saying, no, we're not willing to take him home. That's different. But if everybody's on board and he's made this decision, then we need to rally as a interdisciplinary team to figure out how to collaborate with home health and outpatient therapists. Try to get their phone numbers and actually call them and connect with them, communicate what the actual functional goals are and current progress, pass on any of those quality of life measurements or patient-reported outcome measures, develop a caregiver support guide for his wife and family members. That's something I like to encourage, again, interdisciplinary, so OT, PT, and SLP create a document together that's like, these are all of the things that a caregiver would need to know about eating, transfers, cognition, everything. And that way you can then have a conversation about caregiving as well, and encouraging the family to seek maybe like paying for help or getting other family members to provide assistance. And then that immediate coordination of resources, equipment, referrals, and community supports. So that is, instead of saying like, oh, we know you really, really want to go home, but you have to stay here because you haven't made enough progress in therapy, is generally kind of the conversation that I've seen happen. So in the traditional medical model, the central focus in this case is the brain injury. The treatment goals are to measure visual attention, memory, and safety, and then we're going to measure success by have the signs and symptoms of the TBI been reduced. And that could be done with lots of different tests that we have, right? But with the empowerment model, the central focus is Brian. The treatment goals, we are trying to measure his ability to return to work, be with his kids, and help his wife, and that's a totally different measurement strategy than looking at left neglect or if he can remember a list of 5 random items. So then we're looking at, is he able to live a life that is meaningful to him? So again, looking at quality of life and patient-reported outcome measures. So the CLQT is a good example of a test that fits with the traditional medical model compared to the FAVORS, which is looking at much more functional abilities that are kind of everyday tasks. And that fits much more with the empowerment model. And if you can get it even closer to what the patient is actually going to be doing on a day-to-day basis, even better. But again, that requires those patient-reported outcome measures and getting that system set up. All right. Any thoughts or questions about this model before we go to the next case study? All right. So next, we've got Anju. Anju is a 62-year-old female who just had anterior spinal surgery. Per the MBSS report, she is aspirating on thin liquids. Various strategies were trialed during the test. The only successful strategy was small sips, which reduced the risk, though did not completely resolve it. The evaluating SLP did try nectar-thick liquids, which did resolve the risk of aspiration. The report concluded that the patient should be on a softer diet with nectar-thick liquids. Anju is unhappy with this and does not want to drink thickened liquids. She is dehydrated and at risk for a UTI. So the first question that we can ask her is, what is your understanding of where you are with your health? And she says, it's hard for me to swallow because of my surgery. My doctor told me that my neck is swollen and this is why. I'm thirsty all the time and I don't want that thickened stuff. And then we can maybe infer that she has some gaps in knowledge that we can address, including the risk of aspiration pneumonia, contributors to aspiration pneumonia, and strategies to make thickened liquids more palatable. So maybe starting off with describing the anatomy and physiology, just making sure that she understands when people are using words like aspiration, does she know what that means? Is she able to visualize and describe it back to you in her own words? And then instead of saying like, absolutely for safety's sake, you have to follow these guidelines, we can look at the research that shows that there are 3 different pillars to the risk of aspiration pneumonia. And we can talk about the importance of oral health, and we can talk about the presence of aspiration and the immune system status, and we can talk about what we can control in this situation, which is her oral health, and maybe a little bit control over her immune system status as far as getting enough sleep and eating well and staying healthy. And then we can talk about the fact that we really can't control the presence of aspiration given the edema after her surgery. And then we can point out, like, if we can control the oral health and the immune system status, we really have no risk of aspiration pneumonia. But again, we're not trying to push her to make one decision or another, but we're trying to point out ways that she can stay as healthy as possible within the context of what's going on with her body. And then we can talk about all the fun ways to make thickened liquids a little bit more palatable, whether that's popsicles or using Crystal Light or any of her favorite drinks, and talking about the different types of thickeners and seeing if one works better than the other. Again, not trying to push her to make the decision to use thickened liquids, but just giving her more information to make that choice for herself. When we ask, what are your worries for the future? She says she's worried about being controlled and told what to do by the healthcare system, and that she's really having second thoughts about the spinal surgery, and she felt like she was pressured into it. And I don't know about you as people that are in the healthcare system, and also if you've worked with women, female patients, this is the common thread that I see a lot, where women especially feel like they do not have a choice and they get pressured into things, and they kind of get into the system and they go further down the road, and it seems like every step along the way they're giving up more independence, and more people are making decisions for them. And I've often seen that thickened liquids are like the straw that broke the camel's back, and it's like the last thing that they want to be able, that they're willing to do, because it's just one more way of feeling controlled. When we ask, what are your hopes and priorities? She says, be able to get back to normal life, back to her job, spending time with her young grandchildren, and of course, getting out of the facility. She's willing to sacrifice the time and effort spent in recovering from surgery, but she's really not willing to sacrifice her own autonomy and personal choice and quality of life, which for her is cold ice water. So then we have a conversation about like, okay, what are the options? And again, not placing one above the other or pushing one over the other, but just stating like she can choose to drink thin liquids with small sips, maintain a strong immune system, do consistent oral care to reduce that aspiration risk, or she can drink nectar-thick liquids for the short term until edema goes down, maybe using some strategies to make it more tasty and palatable. And then she says that her choice is that she wants to drink what she wants. And then we ask, how can we best support this choice so we can document patient education and patient choice? So again, rather than saying patient is non-compliant with SLP diet recommendations, we can say patient has been provided with written and verbal education about the risks of aspiration, the anatomy and physiology of the swallow, the various options available to her, and has made this choice that is in line with her own values. We can communicate the patient choice with the physician, and then we can also provide information to the physician, like saying, hey, we really talked a lot about oral care and the immune system status, and those are things that we're focusing on, so anything that you can do on your end to help us as a team fight this aspiration risk would be great. A lot of facilities have the variance form, so facilitating a really smooth, simple, and easy signing of that variance form without inducing any guilt or shame, and then communicating the patient choice without judgment to the OT and PT and other team members. And I don't know about you, but I've seen a lot of kind of when this decision is communicated, it's sort of like, well, I tried to tell them, like I tried my best, and they're non-compliant and they're gonna do what they wanna do, and it's sort of like this hands in the air versus truly honoring this person and what she's been through and having, like taking the time to go through all of the education and checking in with her health literacy abilities, going over all the options and making a truly informed choice and respecting that. So in the traditional medical model, the focus is the dysphagia. The treatment goals are all about reducing the risk of aspiration pneumonia, and success is measured by has the person gotten pneumonia or not. In the empowerment model, the central focus is on Jew. The treatment goals center around optimizing her quality of life within the risks associated with the surgery, which was her original reason for coming in. And then we measure success not necessarily by looking at the presence of pneumonia, but is she able to make an informed decision that aligns with her values? So you could even write a short-term goal that's like patient will participate in 2 educational therapy sessions covering these topics in order to make an informed decision that aligns with her values. All right, I promised a pediatric case. So we're going to talk about Sam. Sam is an 8-year-old boy with fetal alcohol spectrum disorder. He receives many services at school, including speech therapy, where he works on receptive and expressive language, as well as cognitive strategies around attention and processing. His teacher reports that he often has difficulty slowing down before speaking or acting, which can get him into trouble. The other students can sometimes become frustrated with his behavior, saying that it is distracting. He lives at home with his mom, an attorney who recently made partner at her firm. His dad is not in his life, and he has no other siblings. So you can adapt these questions if you're working with a caregiver or you're working with a parent. But basically, you're asking the same His mom says that I understand that he struggles more than the other kids, but I also think people aren't very patient with him. When he's at home, he's very kind and sweet. He loves to play the piano and talks kindly to strangers at the grocery store. Sometimes he has tantrums, but don't all kids? It feels like every time I try to talk to the teacher to find solutions, she is hostile towards me. And I'm just going to play a clip from a course that we offered about fetal alcohol spectrum disorder because they had a ton of facts that I had no idea about. So I'll play that real quick.
Developmental disabilities worldwide. Something that we're not talking about enough, especially in the speech language pathology world, is how prevalent and how big of an issue these kids have and these adults have when they have undiagnosed FASD and when they get exposed to prenatal alcohol. These can occur anywhere and any time a pregnant woman drinks. There is no proven safe amount of alcohol during pregnancy or while breastfeeding. That's a common misconception too. But what happens is the person who's doing the breastfeeding is metabolizing that alcohol in such a way that it is actually coming out at the same level. The milk is the same blood alcohol level as the person who's doing breastfeeding. 50% of pregnancies are unplanned. 50%. That's a pretty big percentage there. And then if you think about, I don't know if anybody on the lecture today has been pregnant or has known someone who is pregnant, but most pregnant people do not find out that they're pregnant until around 6 to 8 weeks. And then if you combine that with this 50% of pregnancies being unplanned, you can see how easy it is to expose a fetus to alcohol.
That was Elizabeth Cleveland, and she taught the course Fetal Alcohol Spectrum Disorders from Identification to Intervention. Okay, so if we ask the mom, is there anything you wish you knew more about regarding your child's development? She asks, why does he have so much trouble at school and not at home? Will it ever get better at school? And she may or may not say, like, is this all my fault? Or maybe you're getting this sense of like defensiveness or guilt or shame that she is feeling just based on the culture of the school system. So again, I mean, anytime that we can provide information that is written that helps kind of outline the facts, providing resources, talking about how to use visual schedules, and then maybe referring the mom to the Birth Mothers Network, letting her know that there are lots and lots of other mothers out there that are going through this experience. She's not alone, trying to take the stigma out of it, take away that shame, take away that guilt, give her some community and some connection. If we ask, what are your worries for the future? She says that Sam is bullied, that teachers won't give him a chance, that he will never feel safe at school, that he will only be seen for his deficits. Her hopes and priorities are for Sam to be able to have friends at school, for him to be able to learn in school, for teachers to understand the situation. And again, this may or may not actually be verbalized, but she doesn't want to feel blame her whole life to know that Sam can still have a good life in spite of what happened in utero. If we ask what she's willing to do and what she's not willing to do, she's willing to spend the time and resources to attend meetings to ensure that Sam is getting the support he needs. She's willing to be open about his diagnosis and the implications that it has for her as a mother, which is huge. And I think just, again, bearing witness to that and listening and being there as a support to acknowledge that is really important. But she's really not willing to have negative reactions from teachers and other staff about the situation. And then, again, this is a great opportunity to talk about all of the different options so they could consider an alternative school that may be a better fit. And I know you can't always say these kinds of things in a public school setting, but you can work with administrators to kind of figure out what the right language is to communicate these ideas. You can work with the school to provide better training for teachers and staff around FASD. Consider a special ed classroom where he would have more attention, but cognitively he'd probably be above and beyond everyone else in the classroom. Integrate strategies across all school settings, including the use of visual schedules, extra visual cues, short instructions, and frequent sensory breaks. And I think this is where the SLP is invaluable in the school setting, in making sure that it is an integrated strategy across all of the settings. They could consider homeschooling with services coming in to assist. They could consider a different teacher. So just getting really creative about what are all of the different options. And then asking his mom what her choice is, and she says, I would like for Sam to stay at school with the same teacher. I don't want him to have to switch things around in his life every time someone doesn't understand his situation. I would like the staff to have more training about FASD. I would like for him to have an IEP but be in a regular classroom. So again, this is another great place where an SLP can step in and provide that education for other staff members, or maybe recruit somebody from an organization and have them come into the school and provide information. We can write the IEP in support of not only his cognition and language goals, but really working with staff to understand the use of all of the strategies and how to use those effectively. And if possible, working one-on-one in the classroom with the teacher to address any gaps in her understanding of FASD to reduce the hostility towards the mother. So again, in the traditional medical model, the central focus is the fetal alcohol spectrum disorder. The treatment goals really are related to making sure that Sam fits into the educational system, and success is measured by if he can behave correctly within that educational system. And in the empowerment model, the central focus is Sam and his mom. And we're really working on goals that optimize collaboration and an understanding of the diagnosis. And at the end of the day, what we really care about is, does Sam have the support he needs to succeed in a structured environment, since that's what his mom is choosing. All right, those are my case studies. Any thoughts or questions? I just threw this slide in here because I recently met with a doula, and like I have a lot of fears around labor and delivery. So I'm like, I'm gonna get somebody on my side. And before I met with her, I had like all my questions written out for her. And she totally surprised me because we met and she immediately started asking me questions. And these are the questions she asked. So she's like, what are your fears and concerns right now? What does your support system look like? What is your philosophy about healthcare? What has worked for you and what hasn't worked for you? And what is your idea of what a doula is? And by the end of our meeting, we spent like an hour together, and I think I had asked like one question, and she had asked me all of the questions as the patient. And it just like reinforced to me how powerful it is to be on the receiving end of this when you feel heard and you feel like I'm able to voice what I need and they're really listening, and then I know that we're gonna have a good relationship and a good interaction. All right, I'm gonna switch gears and do this little transition talking about how the empowerment model can really help us help us to create an environment that has a lot more diversity in our field. Because I think the empowerment model allows us to hold multiple perspectives at the same time, which is what diversity requires. And right now, as it currently stands, within the traditional medical model and within the current state of diversity of our field, it's really a binary choice. You either belong or you don't belong. Like you either do this thing I say you should do or you don't do it. And I think collectively as a culture, and I think we've seen this over the last couple of years, we're trying to shift towards having that capacity to hold multiple perspectives at the same time. And my fascination with diversity in speech pathology started in 2015 in Denver. Was anybody at that conference? I lived in Boulder at the time, so it was easy for me to go. But I also remember, so I decided to apply to grad school at CU, and it was the only school I applied to. And I remember, like, they had this cool video where they interviewed a lot of adult patients talking about their experience in speech therapy. And I was like, that is so cool. Like, that's the perfect combination of art and science. But I did not know any speech therapists. And when I walked into the orientation or information session at CU, I walked into the room and I was like, am I in the wrong room? Like, is this the information session? Because everybody in the room looked like me. And I just, I had no preconceived idea of what a speech therapist looked like. I just thought it looked like a really cool job. And then when I went to the ASHA convention in Denver, so this is right around the time that I graduated from grad school, I went to the keynote speaker, and it was in this massive room, and I didn't know anybody, so I was sitting there by myself. And there were a couple of people from the ASHA board of directors talking, and they were very much speaking about the diversity of speech pathology and really hyping it up and celebrating it. And again, I was looking around the room and I was like, is this a joke? Is this happening? Are we really celebrating this? Because I don't see a lot of diversity. And it was just very confusing for me because I had come from geosciences. I had worked around the world. I'd worked with all different kinds of people, all different kinds of languages and backgrounds and identities. And it was so much fun. I learned so much from everybody because there were different perspectives. People disagreed. I think if you look at earth sciences as a field, there's just a lot of dynamic conversation and different theories going on. And there's that push and pull, whereas everywhere I looked, these are just random photos of the convention, but I was like, I just don't, I'm not seeing the diversity, which is not, it's not ASHA's fault. It's just the reality that we're in. And these are all numbers from the 2020 member and affiliate profile by ASHA. And so 4.5% of SLPs identify as men, 3.6% identify as Black, 6.1% identify as Latine, 0.3% identify as American Indian or Alaska Native, 3.1% identify as Asian, and then I put the US population representation in there for reference, just because obviously we serve a very, very diverse range of people, and we should be a lot more closely aligned with the representative score of the country. And we're not alone in this. Physical therapy has the same problem, maybe even a little bit less diverse. Same with occupational therapy. And I think, my theory is, how we got here is that there's a certain, I'll pull up this slide, there's a certain image that people have of a speech therapist. And when people don't fit that image, it's hard for the field collectively, maybe not for individuals, but collectively, we just have a really hard time holding capacity for different backgrounds. And I also experienced this at CU when I was in grad school, because I went back to grad school later in life, so I'd had all this different experience. And I really struggled because I didn't fit that traditional role of an undergraduate student going straight into grad school. So I had all these different perspectives and ideas, lots of job experience, had lived around the world, and then when I didn't give the answer that they were looking for, it didn't go well. So I think what ends up happening when you have that kind of a culture in grad school, in the professional environment, there's just this monolithic culture and this homogeneity. And I agree with this quote that it really breeds weakness and theoretical blind spots, stale paradigms, an echo chamber mentality, and cults of personality. And I think we can see this in speech pathology because a lot of the same ideas get recycled. We end up arguing, is MBSS better or is fees better, when in fact they're just two very different things, and maybe we're missing out on like the 5 other options that could be available if we were innovating. But innovation takes people with different ideas to step in and be able to safely share those ideas and then grow those ideas. And I think that's the culture that we're missing right now in speech pathology. And it reminded me of my friend Betty, who's a 4th grade teacher in Crystal Lake, Illinois. And she and I spent time together in Antarctica, and what she would do is at the beginning of the school year, she would have her students, her 4th grade students, draw a picture of a scientist. And most of the kids would draw a male with crazy hair doing like a ridiculous lab experiment. And then the whole year she would spend talking about all of the different scientists that she had met around the world. She would show photos, she would talk about their research, she would do phone calls or video chats with scientists all over the place. And then she would, at the end of the year, ask them to draw a picture of a scientist, and inevitably they would be totally different representations of what a scientist looked like. And I think this is the shift that needs to take place in speech pathology, and I feel like people like me are in a position to advocate for that shift, but we're also I'm not necessarily in a position to make it happen. And so after, let's see, was it last year in 2020 where the Black Lives Matter movement got a big boost of energy, and I got called out for being a white woman who was trying to make change without having other voices with me. And that was a big lesson that I learned. And so I started reaching out to the community of clinicians that I know around the world, and these are the people that responded. And so we spent the last year kind of framing out this idea for the Cultural Expansion Cooperative. And just read, our mission is to foster conversations, create resources, and hold space so that a broader base of backgrounds, life experiences, and cultures can be integrated into the fields of speech, occupational, and physical therapy. As historically monolithic groups with deeply ingrained patterns of beliefs, behaviors, and unconscious agreements to keep things the way they always have been, we are missing out on an extraordinary range of humanity. We as clinicians suffer because there is no fertile soil for truly innovative and expansive ideas, which at their core require the push and pull of different perspectives. Our clients suffer because we collectively do not have the tools, resources, or capacity to truly meet them where they are. Let's change this. So what I did is I kind of backed off and I asked this team, like, what do you think that we should do that would actually move the needle? And I was also frustrated because I feel like what happens is, like during the Black Lives Matter increase in energy, or the Black Lives Matter movement, there's kind of this spike of interest, and it's like, oh my gosh, we have to do something, we have to make it better. And everybody says things on social media, and everybody makes a statement, and then it kind of dies down, and then we are like at the status quo and where we've always been. And then it'll like ramp up in another year and the same thing of like, OMG, we have to do something, we have to make a change, this has to get better. And then it's just kind of like this cycle of spikes. And so I asked them what we could do that was slow and steady, like I said, that would actually move the needle. So we have a health literacy team, and the idea here is to improve health literacy with non-English patient education handouts released monthly This is a piece of feedback I've gotten from all kinds of clinicians around the world, is that there are just very, very few, especially adult-related speech therapy handouts for people who do not speak English. And I think in the United States, we're still very lucky to have a huge immigrant population of people of all different backgrounds. And so we need to be able to offer materials that are in other languages. And so again, I reached out and got a huge response. So we've built this army of translators that speak all of these different languages and have clinical experience. And we're looking for somebody who speaks Somali who has clinical experience for the Somali population in Minnesota. So if you know of anybody, let me know. And we have plans to slowly but surely be able to translate as many of our materials as we can into as many other languages as we can over time. And then they also wanted to create a podcast and release a new episode every month that centers the voices of clinicians from all walks of life. And I'm just going to play a preview, like a short little clip of an interview they did with Martian Pillay. And you can see on the right, he's worked all over the world. He's an audiologist and speech pathologist. And just for some context, they're talking about how we can make small changes in the field to make things better.
One of the things for me has been to make a noise about the need to change, first of all. So since starting, my very first research project was in 1992, and I did a study looking at indigenous healthcare. So I looked at isiZulu traditional healers, who are referred colloquially and ignorantly as witch doctors. And I spent about a year in a beautiful place called the Valley of a Thousand Hills in KwaZulu-Natal. And basically just hung around with the Nyangas, as they're called, and essentially looked at the values and belief systems that isiZulu people use and cross-reference when. And my question to them was, what happens if you were presented with a person who had a speech or hearing or swallowing disorder? What would you do? And of course, it was exactly the wrong question to ask. And so I learned through that kind of research study was that I was imposing a Western imperial framework on trying to understand in an indigenous knowledge system. And so as a result of that, it sort of shot me into making, like I said, a loud noise around the way in which our education didn't meet the values and beliefs of people in our country. And isiZulu speakers are predominantly, they're about 80% in South Africa. So
I'm super excited because I've listened to, I think they've done 3 interviews, and then they're going to do roundtable discussions. And if I can go back. So they all have their own perspective that they'll be able to discuss on the podcast. So keep an eye out for that.
one of the things.
And then they also decided that we needed a safe space. So we're going to do every other month Zoom calls for learning about and sharing experiences of racial and cultural divides and how this impacts the field of rehabilitation. So this will be a place for people like me to go and ask questions like, I don't think I understand, or is there something I could do differently, or a way that I could phrase this differently, and get advice and feedback on that. And also a space where people who are underrepresented in our field can talk about the challenges that they're experiencing with microaggressions and other experiences of being kind of misunderstood and marginalized. And then we are having an outreach team with Stephanie and Susie. So their idea is to inspire high school students and early undergraduate students to consider a career in speech, occupational, or physical therapy, and really challenge what the stereotypical therapist looks like. So this is me giving a presentation at the University of Montana. I think it was like a Bio 101 course or something. but just trying to like catch people in that moment where they might be making a decision about which field to go into, and maybe they've never heard of speech pathology, like I had never heard of it, and they don't know anyone in the field. And then if they do any research and they're like, oh, I'm not a white woman, I wouldn't fit in, we're gonna have videos of speech therapists from all around the world talking about their careers within the presentation so that they can see that there are therapists that look like them. So, as we're wrapping up here, if you want to hear about the latest events and new podcast episodes from the Cultural Expansion Cooperative, you can go to our website. The best way is to sign up for our newsletter. And then we're also on Instagram, and we'll be posting a lot there. I'm hoping to launch this in December, and there is nothing like a pregnancy due date to motivate me. So my final thought for all of you is that we are the ones that can truly transform the current healthcare model from authoritative to empowering. And it's a very simple way to do this, but all we have to do is ask questions and stay curious. So thank you very much. And happy to entertain any questions or thoughts or conversation. Yeah.
Do you have any tips on how to support a patient who's trying to navigate the traditional model of healthcare professionals and advocate for themselves with a lens of the empowerment medical model?
It's so hard because I feel like, so just to clarify, you're asking like advice for a patient to advocate for themselves and say like, hey, I want to be able to make my own choices and I don't want to be in a system where you're dictating. Because what I have seen is people who tend to have that traditional medical model experience, they go to the doctor, they're told what to do, they're shamed for not doing it, and then they never go back. And that's super unfortunate. And I feel like the skill that it takes to be able to advocate for yourself is so high. Like I know all of this, and every time I go to the doctor, I'm still just like, oh my God. Like they took some blood work for me and they were like, well, you're doing pretty good for a vegetarian. And I was like, well, I mean, vegetarian is like, it's an okay choice. And I shouldn't have to feel shamed or guilt about that because I'm pregnant and choosing to be that way. But at the same time, like I think that patients need to be told explicitly, like you have the right to say, I'm not going to do this, and kind of being an advocate for them and training them how to have those conversations might be helpful. But I feel like it's so hard.
I didn't know if you had any handouts, just letting them know, like, what are your goals, what are your choices, would just be helpful.
Mm-hmm. Yeah, I think the more information that we can give them within the context of saying, like, I'm here to give you all the information you need to make the choice that's right for you. I know that you're talking to 12 other healthcare providers today, and they all have different advice, and they all have different agendas for you. At the end of the day, we're here to support you. But that's not the message they're going to get from everybody. So I don't know what we do about that, other than continue to be an advocate and a support system for them. And I think, too, it's a trickle effect. Like, once one person on the team is behaving this way and talking this way, other people start to be like, oh, that's different. And it's especially true when it's a situation like the person wants to go home and the team doesn't think they're ready. Like, all it takes is for one person to say, it doesn't matter what we think, it's their choice, as long as they're able to go home and all that. But I think what happens is this group think takes hold, and then this, as long as everybody's on board with the agreed idea of what should happen, then that just kind of like grips itself. But if one person steps away from that, I think it can be powerful. Yeah.
So kind of looking in the other direction, you've had a lot of experience with providers. You do this education with the patient and they've made their choice. They understand what their options are, they've made their choices. We're advocating for their choices, and the provider's like, well, that's a quality of life diet, we need to make them a DNR. Because this happens a lot. So then I have the conversation with them, like, your COPDers that keep smoking, come in with exacerbations, or your alcoholics that have had all the education, go home, keep coming back with tremors, seizures, whatever. We don't stop treating them. We don't make them become a DNR. Why is someone who wants to drink liquids that they have every right to drink, why are they different? So I just know if you've had any other thoughts or experience.
Do you feel like you can have a conversation at all?
With a lot of them, I work pretty closely with our palliative care team, and so we work together a lot. But there are definitely some doctors who are like, nope, they're aspirating, they're going to get pneumonia, they're going to die, we need to make them a DNR. We're not going to intubate them every time they come in with aspiration pneumonia. And they're like, yeah, but they also have esophageal dysmotility. Like, it doesn't necessarily mean they're aspirating their thin liquids and coming with pneumonia.
Right.
They could be laying flat in their bed and coming in, or whatever else is going on. But so I just know, the especially staunchy ones.
Right. Well, and I feel like I've gotten lucky in that a lot of providers I've worked with, they already have adopted this model. So I feel like if you can find one and then like get them, because maybe they'll be more likely to listen to a colleague that's at their level or whatever, however they see that.
Every copy of that book that was right now, and she gave me a copy. She's given copies to everyone. Everyone in the office, from Dr. Sunday, but there are some in there, but they're just, it's difficult.
It's so hard because it's, like I said, it's the water we're all swimming in. So like anybody going against this is seen as not cooperating. Like it's like this pyramid scheme. It's like as long as everybody's cooperating and doing what they're being told to do, then it works. But as soon as one person is like, no, we're all humans and get to make our own choices, then you encounter that friction. But I think it's just all about building relationships and mutual trust and rapport and respect and like not letting it devolve into a power struggle. And I think like the same strategies we use with patients as far as asking questions can be just as powerful. So instead of going to a physician and saying, here's all the information that you should know, like asking, like, can you give me more information about why you think this way? Can you give me some references that you've been looking at lately to help me understand where you're coming from? Might be a place to start to at least build the relationship. And then from there, sending them the podcast or the book or whatever. Yeah.
Any consolation, I do think that, I mean, it's getting so much better. You know, it's much easier to be in relationship with providers than it used to be. And really that's just send a message, you know, that says this is my observation, and so many times you'll be surprised that they'll write back to you for more information, you know, and thank you. And I know in our internal medicine residency program, I mean, there's a lot of this kind of theory going on.
Yeah. Yeah.
So much better than it used to be.
I think Atul Gawande's had a huge influence. I mean, he's a major player for sure. So hopefully he inspires others to keep writing and talking about it. And
to also teach your younger colleagues not to be afraid to make that approach, you know.
Yeah.
I mean, there is just nothing special about a doctor. You know, I mean, when it comes right down to it, they are just like you. They probably have more depth than you, but I mean, they're just like you. And talk to them.
yeah. Anything else? Thank you. It was a pleasure spending time with everybody, and enjoy the conference.